Hi, everyone, and welcome to our presentation entitled Effectively Communicating with Deaf and Hard of Hearing Patients. The Yukon Health Community-Based Education Office and the Center for Excellence in Developmental Disabilities partnered to offer this educational exchange. Our presenters will share strategies for working with deaf and hard of hearing patients from both the perspective of the deaf patient as well as the ASL interpreter. Our guest speakers are Louisa Sobolewski. She is currently the president of the Connecticut Association of the Deaf, as well as a retired principal from the American School for the Deaf. We also have Lesley Warren, who is a nationally certified sign language interpreter and the CEO of CoSign Connecticut. She's also an adjunct professor at Wesleyan University. Today's agenda will include modes of communication, working with an interpreter, video remote interpreting, and at the end of the presentation, we'll also have some general resources as well as a way for UConn medical students to ask additional questions. So without further ado, please welcome Louisa Sobolewski and Lesley Warren.
Hi, everybody. My name is Lesley Warren, and I am here today to represent interpreting and the interpreting aspect of health issues that come up in medical settings. I am here today as a person who has a lot of experience with interpreting in medical situations. I was the full-time sign language coordinator at UConn Health Center for 12 years, and we developed programs for interpreters to learn how to better serve the deaf community. So I'm happy to be here, and we'll share just a little bit. We'll just touch lightly some of the important points for you. I'll be back in a few minutes to talk about interpreting, but now I'd like to introduce my friend and colleague, Louisa Sobolewski, who will talk to you first. I want to caution you, there's a lot of voicing I will be doing for Louisa, and I might need a little sip of water. So you will see me stop and ask to have a sip of water. That's what interpreters have to do sometimes. Anyway, my friend, Louisa. Hi, everyone. And it's very nice to have this Zoom meeting for all of you. I want to thank everyone for having an interest. And this is great technology for us to have nowadays so we can do this kind of training. I'm a third-generation deaf person. My parents were deaf, and I have 2 deaf children, and I have 4 grandchildren, 3 of whom are deaf. Deaf people, what are they thinking about? What do they thinking about? What is it like being a deaf person? My 3 grandchildren, all of us, have different ASL techniques that they use. If a deaf person is born to a family who can hear, they don't have the same American Sign Language style as children born to deaf parents. Many times, deaf children who are born to hearing parents, and all deaf children, as a matter of fact, have a bit of a language delay. But they can get along fine in life, having a hearing loss with persons who help them in their family, or maybe issues will come up where there's no sign language available to them until later when they get to school. I used to work at the American School for the Deaf, as noted in my credentials. When children arrive at school there, they are very limited, many with hearing parents who don't sign. With language, they are quite a bit limited, and they have to struggle quite a bit to catch up with other children. Deaf children have all kinds of different backgrounds which affect their learning. Some children are deaf and blind with vision problems. Sometimes their age developmentally is a problem. I'd like to talk to you for a moment about modes of communication with deaf persons. There's lip reading, of course, and all deaf people can read lips some. When I grew up, my parents, and my mother especially, she loved to wash dishes, and talk at the same time, to force me to lip read her. And I did that as a young child, and it helped me a lot with my reading skills and my lip reading skills. But not all deaf persons have that kind of experience growing up. I am a good lip reader as a result. American Sign Language, our first language of the deaf, our cultured language. It was founded here at the American School for the Deaf as the first deaf school in the country. And it spread all over the country after it was established here in the 1800s. Do all deaf people sign the same American Sign Language? We call it ASL, actually. It depends on their background, the region of the country that they came in, how many accents they have. Are they from a northern part of the country or south? It's the same with sign language as it is with spoken language. There are different aspects around the country. People in Philadelphia sign the sign for birthday differently than somebody from the Midwest, say. My sign is this: birthday, birthday. I'm showing you all different signs for the word birthday. It's all in America, but the signs are different. Written communication, I must explain to you again that it depends upon the background of the deaf individual who's writing. When you see a person who has been educated and you write notes back to them, they could answer in American Sign Language, and it might look confusing. It might look not right. For example, if they write big house, in Spanish, they put the noun and the verb and the adjective in a different position. American Sign Language is mostly like French because that's where it came to the United States. And deaf people here have different skills in reading written language. Communication for deaf-blind persons is an extremely important need. Some of them can see a little bit, so they can use a close vision interpreter, but some of them who are deaf-blind depend upon touching the hands of an interpreter or another deaf person so they can feel the signs that are being floated through the air. They rest their hands like this, and the interpreter or their deaf friend will just sign into the palm of their hands. That's how deaf-blind communicate. And people who, like me, who can see you and understand you, I can follow you, but they overlap their hands onto the interpreters so they can understand. And now Lesley will talk to you a little bit more about the interpreting piece. So back to me. Thank you, Louisa. I wanted to share with you a little bit about the experience that interpreters have in a healthcare setting. Often your hospital or doctor's office will have a preferred company that they use where they call sign language interpreters. Many of them have a list where they can call. Sometimes it is, well, most of the time, it's very helpful when you make the call or the person on your site makes the call to give as much information as you can on the phone to the agency or business or freelance interpreter who's coming. Often with emergencies especially, the interpreter likes to know what to expect when they arrive. Is it a childbirth? Is it a car accident? Is it a heart attack? And by the way, those two things look the same on the mouth. Heart attack, car accident. So what is the presenting issue? Also, is the patient male or female? Sometimes there are sensitive situations that happen where it's best to send a male or a female interpreter, and that's good to know. When the interpreter arrives on site, the interpreter will likely do a language assessment. They will have a light conversation with the deaf patient if they don't know them. And they will ask them how they're feeling, you okay? Ask them some questions, where are you from? Did you graduate from a school for the deaf? So they will see them signing a little bit so they will know what kind of ASL will work for that individual. If family members are there, it's best to just use the interpreter. The interpreter, by the way, is the other professional in the room. No different than the doctor or nurse. Trained, credentialed, national credentials are required. It's a state law in Connecticut. And these individuals know how to behave in a medical setting. They follow their own code of ethics, professionalism, and they are there to serve you, but not to help the situation. Interpreters also have to, will often ask the healthcare providers, have you worked with an interpreter before? Have you ever had this experience? And they will explain a little bit about the lights not being in the back of their head so they can see. They will position themselves so the deaf person can see them clearly. The interpreter will ask the medical doctor or the nurse to speak directly to the patient, not to speak to the interpreter. And the interpreter will interpret everything. If there's a conversation going on in the room, the interpreter will interpret it. If there's noise or a fight or something going on in the hall, they will interpret what they hear so that the deaf persons have a sense of their environment. I want to tell you a little story. Louisa mentioned about written communication and how important it is, and she also talked to you about American Sign Language. American Sign Language has a different syntax and structure and grammar compared to written or spoken English. So this is an interesting story that happened in a hospital in out west, California. Very bright, brilliant deaf woman was attending a conference and became very ill. She was rushed to the hospital and they called for an interpreter. She was very smart, PhD. And so she arrived very sick. And they called for the interpreter, but it was going to be an hour and a half before the interpreter arrived. So the doctor wanted to ask some questions and wanted to know, he wrote on paper, did you have any childhood illnesses? Were you very ill in your past, in your life? Anything happened to you? And the deaf woman, who didn't want to think in English because she was too sick, she took ASL, American Sign Language, and put it on paper. And this is how she answered. I hope I left that there enough. But anyway, that doesn't look right. It looks wrong. So they called for a psych evaluation in the mental health department of the hospital when they read that. Interpreter arrived, and the interpreter, being the professional that we are, asked some questions, and then the interpreter said, did anything written happen before I arrived? May I see it, please? So they saved the paper, showed the interpreter this, and the interpreter said, can you please ask the question again? And I will interpret it. So the doctor asked, any childhood illnesses in the past? Deaf woman understood, and she signed that ASL, but it interprets with facial expression and eyes like this. What she was saying was, when I was 2.5 years old, I had a high fever and almost died. I didn't die, obviously, but I can't remember seeing any doctor for this. I stayed home for a long time, puzzled. But spinal meningitis, they think I had, but I never remember seeing a doctor for this. So that was the answer. There was no need for a psych eval. So written communication Interpreters will have a lot of answers and can help you through the process with a deaf patient. But the most important thing is for deaf patients to feel like they're in charge of their own health and well-being. So there's a lot more information online that you can get, but those are just a few tips about working with interpreters. Now I'll give it back to Louisa to talk about some other points. Now, as you talk about communication, when you look at a list, when you look online, you will see some basic sign language words that you can learn, very fundamental signs. Maybe here at UConn, you have a little class that you can host. You can involve someone to come in and teach ASL in simple terms so that you can move forward. And you can gesture a little bit. Please understand that gesturing is a very good way to make a deaf person feel comfortable. It's better than doing nothing. It's better than not frightening them that you're not even attempting to talk. Here are a few signs that might be helpful. Hello? Goodbye. Please. Thank you. Where? This is a sign for pain. If you place it in your head or your neck or your stomach, it's like you're asking, where's the pain? Interpreter. Interpreter will come. Interpreter's coming. Wait. The sign for wait. Doctor. Nurse. That's taking the pulse, you see. Bathroom. There's a whole list of very basic signs that would be important for you to know exactly what would help you. Supposing you don't know the deaf patient and you just give up trying to talk to them. If you have one or two simple sentences that you know, it will help them feel better. And it will help people in the hospital know that the deaf patient and you know some of the same signs. So work with the deaf patient and the interpreter. The interpreter has to choose their words carefully. For example, if someone wants to say the word run, there are many different meanings to the word run. Running in a race, running to the store, running down the street, meeting a person, running into a person. These are all different signs. Running a meeting. You see the different signs that all go with the one word, run. It's very important that you know which sign or gesture to make the correct meaning for the deaf patient. Sometimes the deaf person will continue talking, will stop talking, and you will see that the interpreter keeps talking like Lesley's doing right now. This means that you have to allow the interpreter some time to translate the ASL that they're seeing into written or spoken English. It takes a few moments. Now, about deaf culture, we do some things that people might misconstrue as behavioral and not cultural. We have a very strong culture within our community. In our culture, we tend to pat people on the back, we hug a lot, we throw our arms around people easily, we shout when we can't get somebody's attention, we tap our foot, we bang our foot when something's troubling and people aren't paying attention to us. This is not a behavior issue, it's our cultural issue. And it's a way that we get attention. My children can't hear me, so I would flash lights in the house to get their attention. We do all kinds of things to adjust. Instead of having to walk upstairs to tell my kids and flash the lights on and off, we develop mechanisms in our house whereby we can function with lights as a cue. Facial expression is so important. If you look like this, they think you're mad. We think you're angry. somewhat, one time I brought my lunch to my husband at his place of work. And I gave him his lunch, and I was signing back and forth to him. And I was explaining what happened to him with some incident that happened at home or something. And his expression, I was making an expression to him like angry and just telling him my story. And later, everything was fine and we left. When he went back to work, somebody at work said, "What were you fighting with your wife about?" You were fighting. You were waiting in the car and you handed him, she handed you some lunch or something. The expression that I was using was just showing the details of a story of something that happened at home. It was not a fight. It's how we communicate. Our facial expression is very exaggerated sometimes and can give the wrong message. But it's very important for doctors and nurses to know that their deaf people are going to look at your face and your eyes, and they're going to try to read information from that. If you want to ask the doctor a question and the interpreter interprets a question and the patient looks puzzled like this, means maybe you didn't understand the information. It's not often the interpreter's fault. You should pick up on that and repeat the question. Study the deaf person's face. They have a right to do whatever natural and comfortable for them. The interpreter and the deaf person has a right to ask a doctor or nurse to repeat something if they don't understand, but their face might look angry. There are so many different things to think about in our culture when communicating. Now, if you won't mind, I'd like to talk for a moment about video relay interpreting. Video relay interpreting, we call VRI, is not effective for all deaf people. You need to know that, or hard of hearing people, or deaf-blind people especially. You cannot use a VRI, speaking about deaf-blind, for everyone, but especially not deaf-blind. There's a visual limitation to the screen. It's a small screen. And if I am very, very sick and I'm lying in a hospital bed, and there I am, a VRI is not going to work for me. I can't pick my head up to strain to read an interpreter. If I'm in a lot of pain, I don't want to trouble myself trying to focus on a screen. I would want, on a two-dimensional screen, I would want an interpreter to come. It's not good to use VRI for all situations. And again, especially with deaf-blind people who need tactile signing. VRI is a screen. You can't punch your hands through the screen and do that. It does not work for deaf-blind individuals. Environmentally, having everybody in the room, more than one deaf person in the room, is not, it's not an effective way to keep the attention of the deaf patient on you. There was one article I gave the hospital here to think about. Parents were both deaf and their little child was hearing. And the doctor was trying to get an interpreter and couldn't get an interpreter. So asked the little child if the child would be the interpreter, because the child could hear and the child was young. And the parents were like, absolutely not. This is not a good idea. Family members, children especially, they mess up the information. They're not always clear. This is why this article I sent to the hospital, which I believe you can access, explains why you should not ever use family members to interpret in a hospital situation. It is very emotional when people are sick. It does not allow for good communication for detail and understanding. If you see a deaf child talking to his parents, that's good. That's fine. They can be there and help gesture or communicate until the interpreter can come. And that's fine. But if it's a mother with a child, let them talk and communicate, but get an interpreter there as well. I think it's awesome when people attempt to gesture, but do not ever use a deaf child to interpret for parents. Video relay, the screen sometimes becomes very hazy. It freezes up. The voice is not clear. The interpreters, again, might be delayed, language delayed, and it frustrates the healthcare providers. It'll become difficult for the person to understand sometimes because VRI operators are from all over the country. There's signs in Montana and Texas are different from the signs in the Northeast, some of them. Here, for example, in Connecticut, we have Hartford. That's what Hartford looks like. It's the letter H, Hartford in the air. An interpreter from Utah or somewhere else in the country would not recognize that sign. They don't know what that is. It's a regional sign that regional interpreters would know. This is a very sticky situation. So it's okay for the VRI to be used before the interpreter arrives often. I want to explain an experience I had when I had my C-section and I was in the hospital. My husband, who is deaf, was in the room with me, and I was awake. The interpreting was, everything was all set. Everything worked out fine. The interpreter was all set to come, and the interpreter was there, and I understood everything. And then when it was time for me to go in for my C-section, everyone left, and I went out. The interpreter came in the room with me, let me know I was going to be put to sleep, and that she would be there when I woke up. When I woke up, the first thing I saw off my shoulder was the interpreter signing, "You okay? You're awake now." I felt so safe and so in control. As soon as I opened my eyes, I had an understanding of where I was and what happened because the interpreter was right there for me. And the interpreter, with the doctor's permission, "Do you need ice? Do you need anything? Can I talk to the doctor for you?" This is what professional interpreters do. And it's very important to know that even for a C-section, they have to be there for the whole time. If you're going to use VRI in the hospital, and if you expect that you might use it at any time, please don't let the VRI machine just sit in the hallway or not be used. Check the equipment. Last year I had a nosebleed and I went to the emergency room. I was not in pain or anything, and it was clear to me and it clear to the doctor that I had a nosebleed. I would use VRI for that. That was fine. I was sitting up in a chair. I could see the screen clearly. I can lip read. I can understand regional signs. The doctor came in, but the doctor came in and moved the VRI screen out of the way so that he could see it. I'm like, no, the video relay machine is for me, not you. I have to see it. I have to watch the person signing on the screen. And there's an interpreter here who's interpreting your words. The doctor didn't listen. The doctor didn't understand the whole thing. And I had to go into this big explanation about the VRI machine is for me. Another story I had was my husband had to go into the hospital for a colonoscopy. And his doctor was very, very good with both of us. They knew we were a deaf family. They knew to get an interpreter scheduled. Everything was set, no problem. Monday morning came. It was a Monday. My husband had done all the prep the night before, all the drinks, cleaned himself out and all of that, and arrived at the hospital very early. I went with him early in the morning to have the procedure. We got into the reception area and the woman said, "I'm sorry, there's no interpreter coming," and looked at my husband, and I said, "What do we do? VRI?" And my husband said, "Okay." Because I was there, he said, okay, he would use a VRI. So they bring this VRI machine in. 5 minutes passed, then 10 minutes, struggling with the VRI, trying to get it to work, trying to turn it on, trying to get a picture. Turned into 15, 20 minutes. The computer was not working. The tech person from the hospital came and explained to us that the Friday before, the hospital had converted all the computers over and made a different configuration for their computers and forgot to work on the VRI equipment. So my husband said he didn't really want that, but then the VRI wasn't working anyway. So asked if I could interpret for him. This is not something that should happen. I didn't want to do it. Please, I don't want to do it. And he said, I'm not going to do that prep anymore. I want you to stay and I want to get this over with. So the person who was in charge came in and explained, and this should have not have happened. And I interpreted for my husband as best I could. The nurse apologized and everything was set and we went through it and he was fine. And they were so apologetic about the interpreter and the VRI. Again, it is very important to check that equipment. Don't leave it in some hallway so nobody uses it or shoved in a closet. Because if you have a deaf patient and that's your only means of communicating and then waiting for a long time to make it work, have it ready. Check it periodically to make sure it works so it's ready to go should you need it. And teach your people on your staff how to use it. Another short little story I wanted to share with you. There was one person in the hospital sitting with a meeting and asked me if I could use a VRI, and the VRI came in and I said, I don't need the VRI. Let's just try to communicate the two of us. But I explained to that person, all deaf people are not the same. I'm okay with this right now, but other deaf people would not be able to function well in this kind of environment without a VRI or an interpreter or someone. It's important that you ask the deaf patient or the deaf-blind patient, whatever they want is what you should provide. VRI is awesome. Yes, it is, but not 100% successful with all medical situations and all deaf people. The best idea is to have an interpreter come in any situation. I know that sometimes it's hard overnight to call an interpreter in the middle of the night, but you need to do that for deaf patients, even in the ER. So thank you. I guess that's our presentation for today. Both Louisa and I are very grateful to have this opportunity. We wish you good luck and hope to see you again in real person instead of like this. Hope you enjoyed it. Good luck to all of you. And Louisa is saying we're going to go back and talk about this special COVID coronavirus that's going on. We wanted to add this at the end. Right now, this is very, very frightening time for deaf individuals, for all of us, but for deaf and deaf-blind and hard of hearing people. Imagine going to the hospital and all you see are masks and gowns and faces covered up. Can't read the face, can't read the lips, have no idea what the expression is. Everything's covered up. This is very frightening. Maybe the VRI machine doesn't work. Maybe the deaf person doesn't understand the interpreter on the VRI. Maybe the deaf person can't read, can't breathe. We are suggesting to deaf patients to bring a whiteboard or for you to have them handy with a whiteboard and have a couple of them on hand. So at least you can write bullets of information. You can tell them what their presenting problem is. You have the coronavirus. Put down information that are bullets of information, or please try to gesture. The mask is terrible, frightening for us. The biggest concern for deaf people is for their deaf-blind colleagues. You cannot separate interpreters from a deaf patient who needs care like this. They need to have a live interpreter who does tactile interpreting for deaf-blind. It's very dangerous not to have that. There have been a lot of discussions about deaf and deaf-blind persons coming into the hospital in this environment. It is very frightening. Thank you for your attempt at trying to figure out the best mode to work with those patients. Thank you again. We'll see you next time.
Many thanks to both of you on behalf of the Community-Based Education Office and the UConn Center for Excellence in Developmental Disabilities. Just want to again sincerely thank both Louisa and Lesley for sharing your time and your expertise. We really hope that all of you watching this material find it informative and valuable. And on this slide in particular, we have provided additional websites, publications, and videos for you to explore. And finally, for UConn medical students viewing this presentation, please let us know your thoughts on Husky CT in the same folder where this presentation is located. In the required realms folder, you will find a link to take a brief survey. Here you can evaluate all of the materials posted on Husky CT, including this recording, but also, and probably most importantly, the last item of the survey gives you the opportunity to ask questions. So if there's anything you still want to know about effectively communicating with deaf and hard of hearing patients, or if there's anything you learned here but really want some clarification on, here's a place where you can share your thoughts and questions. We will compile those questions and either prepare another recording or a PowerPoint slide set with responses from our presenters. Again, we hope all of you found this information valuable, and many thanks to both of our talented presenters.